Hello, I'm Jerry Penso, President and CEO of AMGA, and I am delighted to moderate this panel. We have two distinguished guests who will be joining me, and we look forward to a lively dialogue. Just as a reminder, you can type your questions in the chat box or the Q&A, and we'll have time at the end of this session to get to your questions. So start thinking of them or enter them as you go along, and we'll be capturing them and have a chance to answer them. So before we get started, I'd like my two panelists to introduce themselves, talk about their organizations, their roles, and how they intersect, how they interact with Medicare Advantage. So we'll start with you, John. John Lovelace, please go.
Oh, thank you, Jerry. Good afternoon. I'm John Lovelace. I work for UPMC in Pittsburgh. UPMC is an integrated delivery and financing system, which is a large provider system as well as an insurance division. And I'm in the insurance division. My job is the president of government programs. I oversee the Medicare Advantage and special needs plans work that we do, Medicaid, managed long-term services and supports, children's health insurance, and Affordable Care Act operations in the marketplace. So I do some work in behavioral health as well in Medicaid, and I've been here about 25 years. Before I was here, I was pretty much in public behavioral health services, first as a clinician and then as an administrator.
Excellent. Well, thank you, John, and so glad to have you today. And next we'll go to Nick, and let me make sure I get the name right, Loporcaro.
Great. Thanks, Jerry, and thanks for having me. Good afternoon to everybody. Nick Loporcaro, I'm the CEO at Landmark Health. I've been the CEO just a little over 2 years, just celebrated my 2-year anniversary. Spent the better part of the previous 16 years with McKesson Corporation. As you can see from the Canadian flag behind me, I ran our Canadian business. I'm originally from Montreal, and then I came down to the US to run the specialty business and then the pharma business and joined Landmark 2 years ago. Landmark is a comprehensive longitudinal in-home primary care offering for polychronic, very complex, frail, either homebound or home limited patients. That was the original model we had built. We've expanded somewhat since then. And Jerry, as we get into your questions, we credit the Medicare Advantage sort of construct as giving us the opportunity to actually launch the business because we are an at-risk value-based provider. And without the MA structure, we wouldn't have been able to, and with the partnerships, the respective partnerships, probably wouldn't have been able to launch the business.
Well, thank you. And speaking of partnerships, let me not neglect to thank the host, Better Medicare Alliance, and I want to thank them for hosting this session. AMGA is a trade association. We consist of over 400 medical groups and health systems across the country. These are usually multi-specialty, coordinated care model medical groups and health systems. We're in all 50 states, and our mantra is coordinated care. And that's where I want to start, with the idea of coordinated care and how we improve health outcomes. AMGA members, our medical groups and health systems, have moved rapidly towards Medicare Advantage. We do a risk survey every year of our medical groups and health systems to find out where are they moving with regards to risk. And we've seen a dramatic growth in the last 5 years in their Medicare Advantage population compared to traditional Medicare. And what they find is a good match between their infrastructure, which is their care coordination, their information technology, their quality programs, their multi-specialty model, and Medicare Advantage, that payment model. Combine those two together and they are actually able to demonstrate better health outcomes. So I want to hear from each of you how your organization improves health outcomes, and specifically with regards to the Medicare Advantage program. So John, let's start with you.
Oh, great, thanks. We have a couple of interesting takes on this, I think, because we're an integrated delivery system, a large segment of our Medicare Advantage business is with UPMC, the provider system, about 40% actually. But we also operate a network of providers. So we have value-based arrangements with majority of providers, and certainly with ourselves, of course. Those are all value-based arrangements, but we do a lot of business outside of UPMC and in really all large practices, large being more than 100 patients or so, there's some kind of value-based arrangement. In the ones that are smaller, there's really actually mostly P4P arrangements. They're still value-based, but much simpler. We're not a big enough part of anybody's business to really get enough attention, especially what we need. So we've been able to work together with our provider system, particularly to sort of work on best practices out of evidence-based models of care, payment bundles, things that are really informed by the academic medical center part of the University of Pittsburgh, which is, is a large medical school and 6 schools of health-related sciences who partner with us in the thought leadership around how we should where there is better value, where there are opportunities to improve outcomes, where there are opportunities to improve the experience of patients and members, and where we can demonstrate when it's practical, when it's feasible, the benefits of aligning a payer and a provider together. So eliminates lots of administrative redundancies in terms of what your coverage is, what your benefits are, how you've been moving forward. Gives us opportunities to integrate EHR data from the provider side with the claims data we have. So claims data are very useful in lots of ways in terms of seeing where people have been and what they've gotten, but they don't give you much of a sense of people as people. The ability to integrate the analytics around the electronic health record data with the claims data gives a very robust set of analytics on which to build models of care and which to set goals for improvement.
So let me just follow up, John, and then we'll get to you, Nick. Are there specific areas, let's say 2020, 2021, in quality and improving health outcomes that you're going to focus? Is it on the chronic care side, the preventive care side, the inpatient side, maybe the community care side? Where are you going to focus on?
I think our primary focus really is on the chronic care issues. Many people in Medicare, of course, by the time you live long enough for Medicare, you have chronic conditions. The ability to help people stay as healthy as possible and to manage conditions as effectively as possible has a big payoff for members, a big payoff for providers as well. So it's a really very exciting opportunity to think of how those go together. There are efforts in all these areas, of course. We have preventive care and maybe vaccines for COVID-19 perhaps soon, and in terms of interactions in community settings and community-based organizations and addressing social issues in health. How do you supplemental benefits? We've seen a big uptake, and this is our 3rd year of the Managed Long-Term Services Supports Program, which is we have 34,000 dual eligibles in a Medicare Advantage plan, 80% of whom are also in managed LTSS services with us. That's a pretty heavy percentage of people. It's mandatory on the MLTSS side, so people have to enroll in a plan. We're a little mystified by why the 20% didn't, because they had to go to some other plan. But that's a very interesting opportunity to get a much more 360-degree look at people when you're looking at MLTSS services on supporting medical care.
Excellent. I have a quality background, and what I love about quality work is there's no end of targets. There's no end of areas that you can improve on. Nick, let's turn to you. How about your organization? How are you improving health outcomes?
So just to give you a quick snapshot of our model, we're currently in 16 states. We service 120,000 patients, 50 communities. And we have, as I mentioned earlier, it's a longitudinal comprehensive care model. All of our care is given in home. We have no clinics, no bricks and mortars. All of our providers are fully employed, no contractors. And we have an interdisciplinary team, which includes nutritionists, dietitians, social workers, psychiatrists. I mean, we've got over 400 providers as part of our model. So, when we're going into the home, the financial construct real quick is think of a percentage of premium. We set an MLR baseline. We guarantee savings and improve quality, or we don't get paid. That said, the impact we have on our patients is incredible. We're reducing utilization, improving quality of care. And one of the statistics that an analysis we've done in the past year is we're having a very positive impact on mortality as well. Our patients are living, 6 to 9 months longer than they would have been on average relative to not having the type of care that we have. So, very, very impactful with respect to the patients. We work directly with their caregivers. We work with their primary care providers. We don't replace the primary care provider. Think of us as a complement to them. And when you look at our offering in an MA population, the cohort that we're allocated or attributed is 5 to 10% of that population. And on average, it usually runs at about 8%. And the minute we're attributed that population, we're at risk for them as well. And then we've got to engage them in the process. Once engaged, people stay engaged and stay very active in the program. We also look at our patient profiles by acuity levels. So who needs more intense, visits. So if you have what we call an acuity A, that patient could have 18 plus visits a year from a provider, and then an additional 18 visits from other care coordinators, nutritionists, some of our social workers will be going in. I often joke that SDOH is this acronym that everybody throws out there. Our chief behavioral health officer was provider number 2, engaged, 7 years ago. So it's been part of our fabric from the beginning. If you look at our patient satisfaction scores, we're typically in the mid 90s from a satisfaction perspective. High touch points as well with the caregivers and family members. We average at least 8 touch points a year with family members and caregivers as well. So very intense, longitudinal, and a little nostalgic, when you think about it, being in the home and only focused on in-home care. It's 724, by the way. We also offer urgent visit calls. And the nuance for us, what's interesting is because we know the patient so well, that if we are getting an urgent call, it truly is just an episode. We're going in there knowing the patient and can take care of that episode much better than if a 911 call was placed. And and there's consistency as well. It's constantly the same providers, the same interdisciplinary team members that are working with that patient and the family.
Excellent. I was going to pivot to about lowering costs, but you made me think about COVID-19. And Nick, I wanted to follow up with you. How is that changing your model? Are your caregivers able to go in the home? Are they doing more virtually? How are they able to provide those 8 contacts with the patient every month? And how are the needs, as a follow-up question, how are the needs of the patients changing, with regards to COVID-19, their anxiety, maybe behavioral issues and other health concerns?
All great questions. And Jerry, I'd be remiss if I didn't say how proud I am of this team. It's amazing how mission driven our providers are. They were pushing us to make sure that we could go out and source the right amount of PPE so that they could get back in front of, we refer to our patients as our Joes and Josephines, very affectionately. They're our Joes and Josephines. And today I can tell you we're north of 90% back face-to-face visits because we're well sourced on PPE, thanks to the creativity of our sourcing teams. But initially, when we pivoted to remote, we went telephonic right away to make sure that our patients knew we were there for them. And due to the point you just raised, anxiety, right? Here's a patient population that's already suffering from isolation. Now we're telling them, stay home, don't see your grandkids, don't let anybody in. So our call volume increased 5-fold right out of the gates. With the patients that could use video, we switched to video. We did telephonic video out of the gates. Our high acuity patients, urgent cases, we made sure we were still having the in-person visits. But today, like I said, we're north of 90% in the majority of our markets where we're back face-to-face. Now, with respect to COVID, and I'm always very careful on how I frame this so I don't sound shameless, our business, we went from 0 to 25 communities in 5 years. We went from 25 to 50 in 2 years, and that was all pre-COVID. COVID has just ramped up our engagement rates, people calling in, reaching out. So to your question about the need, now our behavioral health teams have been very busy, obviously, with making sure that we're keeping, we're communicating with all our Joes and Josephines, but we've seen the demand not just from our patients on what they need from us, but also prospective and potential partners that are now looking at how do we help them, especially with provider groups that are going to risk and looking at, they're trying to get upstream into the home. We're already there. And so how do we help them with that patient profile and that cohort if they're already at risk for them?
Yeah, they're very accurate representation of what we're seeing in our AMGA member groups. And John, maybe you'll confirm this. For a few months, many of our groups couldn't see their patients or very limited unless it was urgent or emergent only. So they had to treat the patients virtually in their home. And meanwhile, fielding, as you said, maybe 5 to 10 times the number of phone calls and other concerns of patients who were either anxious or had symptoms and needed to know how to access care. So John, maybe describe your situation with COVID-19 and how it impacted the care that you're giving and the care that your organization provides.
Well, in a similar fashion, I think we really had to cut back on both on the provider side and the payer side of us in terms of what kind of home visiting we could do, and moved, like other people, to virtual, telephonic, telemedicine opportunities. The volume of telemedicine calls on the provider side was, went from like 400 a day to 8,000 a day as people closed down offices, and the care that was driven often was drive by, come in the parking lot, we'll come out and see you. Mass. So it really was, people stayed home, and really disruptive in that way. And we're still not really rebounded from the ER volume is still lower than it was pre-COVID. The medical bed volume, the hospital volume is still lower. And some of it will probably not ever come back. One of the interesting parts though has been how much more engaged and willing both providers and patients were to, and members for the health plan, to engage in telephonic and other kinds of telehealth communications when it was kind of the norm instead of the exception. It's really improved no-show rates, particularly in behavioral health. Because it's much easier for people to engage. We have a big behavioral health plan. There's 1 million Medicaid members across Pennsylvania. Almost all that care is virtual, and a lot of it is on landlines. It's not all cell phones and computers. Lots of it on landlines as well as tablets and other devices. So now we're kind of back into sort of steady state and a new normal, as they say. But we really in the MLTSS program, which is really very home based, of course, it's personal care services and is in-home services. It's really been it's really the member's decision whether you want somebody to come to see you or not. Direct care workers have been very just great at keeping up the work. Except the risk to themselves, of course, and their families going back and forth. Been a lot of change in the nursing home admissions are down significantly, as you might imagine. People don't want to go anyway. It's not your first choice of things to do for many people, but it's make people much more reluctant. So more in-home services, less referral to nursing homes, fewer admissions, and more discharges. Now we pretty much give people a choice. If you want us to come and see you, we'll come and see you. With PPE and so forth, and if you'd rather not, we'll do anything you want to do. So that's really been helpful in engaging people. We've, as probably Nick has seen as well, a lot of people are even more isolated than they were before, as he said, and lonely, and you can't go to the grocery store, you can't. People are happy to have someone come visit. Some people are, and happy to talk on the phone. And spend more time than maybe we would even have chosen to spend, but people are, want to catch up and feel connected. So it's great we're able to offer that service at both the provider and the payer side.
Yeah, let me just follow up with that on the Medicare Advantage side. One of the reasons I think our medical groups and health systems really prefer Medicare Advantage as their risk-bearing entity is that they know that these patients are attributed, if that's the right word, or they're accountable for. So a lot of them during the COVID crisis and even afterwards did outreach to their high-risk patients to assure either their behavioral needs or their medical needs, prescription refills, anything that they needed, but they did outreach to make sure that those patients were being taken care of, didn't end up, with complications in the hospital or in the ER unnecessarily. So John, was that your experience also with your MA population?
It was. We have about 200,000 MA members. About 35,000 are duals, and the balance are mostly MA and primarily HMO members. So like other plans, we did early refills. We did lots of calling people. Do you have what you need? Do you need something else? Have you been able to see your doctor? Can we help you reschedule your screening appointments? Because you don't really want to go and have a mammogram when you're, fearful of going outside the building and all. Let's try to reschedule that. So now we're the push now really is trying to get people back into the vaccine, flu vaccine, but we're trying to do some incentives and some outreach around making flu vaccines easier. A lot of the community clinics that we used to sponsor as a plan and as a system have not opened this year because of worries about congregating. So more work with rides to the pharmacy or to your doctor's office, more and more opportunity to sort of reach people where we can. So it's obviously because of the risk-bearing nature of MA, it's to our, both it's the right thing to do, of course, and it's to our advantage to be sure people get what they need to get when they need to get it, because delaying it doesn't help.
Exactly, exactly. Now, let's go back to the cost of care where I was going to go before we went over to COVID. Nick, that's your business model. You have to manage the cost of care for your population. How do you do that? Where are the savings? And, you mentioned your great outcomes already. So how do you do that while simultaneously applying all these extra resources, yet overall lower the cost of care?
It's interesting. The first statement I'm going to make is I always say I'm naive enough to believe that if you make the patient the North Star and you focus on what's right, everything else will follow. This model's been the epitome of that. I will tell you, it takes us time to generate that ROI. We asked for a 3-year commitment. We've gotten better, but now typically by year 2, we're finding our returns. And what won't be surprising is, the individuals that engage early on are usually the sickest. They're the ones in the most need. And I will tell you that interdisciplinary team, right? We're going into the home. We're opening the refrigerator. We're looking around for falling hazards. Are they taking their medications? Involving the pharmacist and nutritionist, and really focused on health. These are polychronic, multimorbid individuals, and as we focus on that, reduction of utilization is number one, obviously, avoidance, and keeping them healthier, right? And by doing that in a very intense model. And it's interesting because on the surface, and you've alluded to it, it's a very costly model up front when you think about it. But the return for what we're generating because of reduction in utilization and avoidance and keeping them healthier, when you're thinking about this population and how they're coded, and what they're costing the system, that 20 to 30% reduction is enormous when it comes to the value that you're generating. And we're increasing quality as well, right? We're closing those gaps. We're making sure that, we're helping our partners as well with their star ratings. So there's a ton of value around that. So the value's there, the opportunity's there. It's not easy. It is intensive. We have our own proprietary platform, which is the underpinnings of what we do. I tell people often, this is sort of a great case study for people, process, and technology. All 3 of them married together, because I can tell you that without our technologies and the processes that drive that, we go, our technology platform even does the scheduling, routing, when a provider needs to be there. And when you look at our model, our providers are seeing 6 patients a day, not 26, right? So when you, again, back to that cost, but the outcomes that are generated, the savings far outweigh the investments that we make.
Fantastic. Let me just follow up with that. You apply a lot of resources to these high-risk, high-cost patients. What have you learned as an organization? What is it very case dependent, or are there certain lessons that you've learned? One example I've learned from AMGA members is many of them have embedded pharmacists, and they've realized how much medication management, refills, keeping patients on the right medicines and medication adjudication is so important to keeping these patients healthy. I'm just wondering, what lessons have you learned about the care team that you've assembled that helps reduce costs?
Well, a lot of credit to our Chief Medical Officer, Michael Lay, who's one of the co-founders, very thoughtful from the get-go on what the composition of that team needed to look like on the interdisciplinary team. So we do have pharmacists, we have a chief pharmacist, and we have pharmacists in our markets because of the polypharmacy aspects. Now, to your question about, each case versus, as we've grown in numbers, and we've invested a lot in our data science teams as well to do that analytics, we continue to learn, right? I call it that sort of flywheel effect as we get more people in more cases and start to listen, and we start to fine tune. It's almost like, think about AI, where we're continually learning, right? And putting that into the system, and that system then feeds into the platform and helps our providers when they're in the field. And we're looking at some of the pillars as part of our offering. Palliative care is one of our pillars. Well, now we've been asked by a lot of our partners to do palliative only outside of this complex care cohort as well. So we've taken those learnings and now started going down different paths, right? There are certain chronic conditions that we've learned a lot more on where we have more impact than others. If you have diabetes, you probably have some other chronic conditions as well, right? And as we've learned that and what we need to do upstream, renal care is another area where we've realized almost 40% of our patient population, need some form of renal care, and we're giving it, but we haven't labeled it as such. And the analytics has brought that to the surface, and we continue to invest in resources around that. And what we do is, for each of those areas, we bring in a thought leader, so that sort of, train the trainer into the marketplaces, but we do have thought leadership for each of those specific areas.
Yeah, you reminded me, we do analytics at AMGA as well. And we did a lot of work in hypertension, and we still do. And we found less than 1 out of 10 patients with hypertension just has hypertension. They often come with other baggage, be it diabetes, heart failure, or behavioral issues. So John, let me turn to you. As a plan, you're really on a fixed budget. So managing the costs is critical to your success. Give me some of the ways that you manage this population effectively to keep the costs down.
There are a couple of major things, I think, that really impact this. One, the primary one, I think, probably is the strength and depth of the value-based relationships with physician groups and with providers. If our incentives, Adrian goes without saying probably, but when your incentives are aligned, you can do a lot better work than when you're working across purposes and trying to either maximize billing or minimize spending, depending on your perspective. So the long look at quality and outcomes, and the influence of not only spend, but also the revenue adjustments around risk adjustment and closing gaps in care are things that really engage providers pretty clearly. We do value-based arrangements in all of our lines of business, but the place we have started was Medicare, in Medicare Advantage, because that's where the most chronic illness is, honestly. And where the opportunities, the levers are probably the easiest to manage. The gaps in care levers are not easy, but it's very clear what they are. The quality scores, it's very clear what they are and where you need to move to hit a cut point and so forth. So I think being able to have that clinical and business conversation with providers is really, that's one key part. A second is we move very heavily and on our side in care coordination around sort of engaging people in health coaching models. So one of the things we've done here as a tool, we have an intervention called Prescription for Wellness, and it's an EHR-based system, which the attending physician can, when they're referring people with smoking cessation or weight management or nutrition coaching, they do it with a prescription. And the uptake when a doctor prescribes something is so much better than when we call people and say you should really do, we invite you to participate. We get much better uptake when someone's doctor has told them to do it, and even the physical prescription makes a difference. So the attending writes a prescription. If we don't hear from the person in a day or two, we call them, say your doctor prescribed this and we're here to help. And it really is, they're time limited interventions. They really are very good. People have much better satisfaction rates. So it's sort of a self-empowerment kind of piece that it helps engage the person in their own care, which is a goal we all have, of course, to move forward. And then the third piece I think probably is really analytics. There are trying to, as Nick had said earlier, right, who to target. There are people who, in our jargon, we would call anti-regressors. So it's more important to put your efforts into people who are not going to, if you have an episode of illness, then they will cost you a lot of money, but they'll get better. And by the time you've figured out what the problem is, they're probably better. So you can have gains like in the old disease management days. We save you money because the person would have gotten better anyway. We're just here in the road. But people who are not going to regress on their own, who will get worse. Hypertension causes other things, right? Especially if it's untreated. And then the fourth probably is the team idea that Nick mentioned. We have very active pharmacist participation in care coordination teams, pharmacy call center, outreach to people around med reconciliation, patient-centered medical homes, and sort of teaming with the providers and the plan people together around coordinating care. So for most of our practices that are significant size, the health plan pays practice-based care managers to work physically in the practice, who deal with practices patients who are members. And they don't treat people, they really do education, coordination, checking, seeing what people are due, closing gaps in care. As you know from I'm sure your own experience, lots of people go to the doctor and they listen and they pay attention, they smile and they go, yes, yes, and they didn't really understand most of what was said, but they're embarrassed to say they don't. And if you have 26 patients in a day, it's hard to go back and say, tell me what I said to you, tell me back. So that ability to kind of help people figure out what the issues are, maybe a simpler language, and what their options are in terms of treating it within what the doctor's ordered is really, those are the big things, I think.
Well,
Yeah,
John, you had me. Oh, please go ahead, Nick.
Gary, if I could just take off from that, it's interesting. The example I use, we used to take my mom to see her doctor, Dr. Hughes, who knew her for 40 years. And, we'd be in the house talking to her and she'd complain about 10 things. We'd get her in front of the doctor and the doctor said, "How are you doing?" She said, "I'm fine." Right? It's kind of like, and then it's got that 15-minute window. Whereas what's interesting with our teams is we know if Josephine's been eating, we know if she's been taking her meds, we know what it's like because we're dealing with, and to John's point, right, is how do you help that provider gather that information? How do we help them communicate? So we have great influence on those patients on, staying true to the therapies and staying on course. Goes back to one of your questions to me earlier on impact. So we see a lot of adherence there. And just, back to your cost question, one of the things I forgot to add was, I'm an engineer by training, operator, good part of my career. And I come into Landmark and I find out, our providers get 175 hours of training before they see their first patient. And every Wednesday afternoon, the whole IDT team comes together to do panel reviews. They're not in the field. I start doing my math going, that's a lot of lost productivity, right? Learned since then the value of that with that team coming together and understanding the patient holistically delivers, a ton of quality and value.
Yeah. And learning, and probably just ongoing rapid cycle improvement and learning. John, I was just going to go back to you. You had me when you started talking about payer provider, partnerships and working together. Everything else after that was gravy, but that was, from an AMGA standpoint, our medical groups realize if they're going to go to risk, they can't do it alone. They're going to need partners, and the partner as a health plan has to be there with them hand in hand to help each bring their own, advantages to help the patient population. The only other example I was going to give back when I was in practice and setting up these population health programs, one of our first things was to call patients after they had been in the hospital or the ER, and we'd call them within 24 hours and check if they picked up their medicines. And you'd be surprised how many, and you probably wouldn't be surprised, but we were surprised how many never picked up their medicine. Even if they had pneumonia, they didn't pick up their antibiotics, and we would intervene at that point. So sometimes it's even the simplest things like that can, prevent another readmission or a costly complication.
Sure. One of the opportunities we've had that's really been very successful in the collaboration is we have regular ongoing, monthly actually, sit downs with the practice management, with the analytic folks from the health plan. 1 month it's finances, 1 month it's quality, 1 month it's improvements. And you go into the kind of cycle, what can we learn in this? How to understand data differently. This is not how, as you know, this is not how doctors practice. You don't practice on population health. Mostly they practice on the patient in front of them. And trying to see the patterns and what happens to people has been really very exciting for people some people have done really, really well at this. We have a large, multi-sited, of course, community medicine practice, which is primarily primary care doctors. And there are hundreds of them actually in this business unit. And the leadership there has really embraced this. And when they do, the leadership embraces it and helps people understand. They create some information pathways for people. They create opportunities. There's a little competition, Dr. Penso, Nick's doing a little better than you are, and maybe it's because of this. And that's kind of, they're pretty transparent about it. Dr. Jones got $50,000 and Dr. Smith got $20,000, and here's why. In an informative way, not in a punishing way. It's really not meant to embarrass people. It's really meant to say, here's an opportunity to learn. So it's really engage people differently as they think about the whole population health opportunities. And realizing people, as on your medicine example, people don't go, there's a big difference if people go for a post-hospital visit within 5 days, whether those who don't, and if they wait 30 days. But in reality, of course, and probably Nick would speak better to this, if you don't feel well and you just got home, you don't really want to get up and go somewhere again. It's just, ugh. You're tired, you're sick, you don't feel well, you're just whatever you are. And if someone's on top of this and coming to see you, and either televisits or real visits, it just makes such a difference.
Excellent. Let me pivot now, and this is a little bit of an abrupt pivot, but I want to hit one of the issues of the day, which is health equity. We surveyed our AMGA groups after the events of this last year, especially with the George Floyd murder. about how they were going to address the issue of diversity and health equity. And they emphasized they really wanted to focus first on health equity and how to reduce disparities in care. Congressman Schwartz earlier today showed some statistics that the Medicare Advantage population has a higher percent than traditional Medicare with regards to African Americans and other minorities. So there's a huge opportunity, I think, in the Medicare Advantage world to begin to address, let's say to continue to address health disparities. So I'm just wondering what your organization, how you're beginning to look at health disparities with your analytics and maybe some of your interventions. And let's start with you, Nick.
So, I mean, obviously out of the gates, we're reliant on our Medicare Advantage partners and our provider group partners on, you know, the population we serve. That said, one of the things that we put a lot of effort on are the providers serving the population. Do they look like, sound like, relate to the population we're serving? So we have, you know, we recruit in our different markets to make sure that we have people that are speaking the same language, can relate. And unfortunately, we've come up across issues where we have, you know, some biases that we've got to work with, and we work with our plan members. That's in our current operating construct. As we look at, you know, the direct contracting model from CMMI, we've applied for it, we've been accepted. We're looking at that. I think now we get to take more control and influence over who do we serve, how do we make that more open by promoting, you know, that profile of provider and individual and group, and hopefully attract those patients and members to come over to use our services. So we've given that a lot of thought as well. And working on, like I said, some, you know, it's not just a disparity on who's being served. It's as we're going into the homes, are we building up that trust and that basis, and, you know, making sure that we're taking away, as to the extent that we can, any of those biases, by the way, both ways. And it's been an interesting challenge for us.
Thanks. John, how about you in your market? How are you beginning to address or continuing to address these disparities?
Well, in a variety of ways. And I think it's one of the places where I think that in this focus of population and health management approach really makes a huge difference. If you ask a provider, everyone will tell you they treat everybody the same. You know, I'm sure they think they do treat everybody the same, but in reality, of course, that doesn't really work quite that way. So the opportunity to use data and information to share with people, let me show you the differences of your Hispanic versus your Black versus your white versus your women versus your men populations. It's informative to people, and it really engages people in a way of I didn't realize this, and how would you one person at a time? You know, each person's different. So data is very important in this process. It's a lot of work at the university side, particularly around thinking about more active efforts around how to recruit new students of color and of different ethnic groups, how to retain them, how to keep people here. This is not a market generally. I mean, the whole climate of Western Pennsylvania, I mean, not the healthcare particularly, it's not relatively attractive to minorities to move here, but because it's sort of a volume problem. If there aren't a lot of people here already, it's hard to find people who look like you, right? So trying to build that core of how to recruit and retain minority physicians, other healthcare providers on the provider side, as well as on the health plan side and then really to focus on where there are particular data that point to these issues where we might have been looking at diabetics management overall. In this case, looking at diabetic management or diabetic drug use between groups of people. You can set some improvement targets as you said about quality. There's always something to improve. You can set some targets around trying to close gaps in disparities in ways that are measurable and that you can see movement, which makes people feel encouraged.
Fantastic. Well, let's follow up then, John. You mentioned Medicaid population, dual eligibles, and of course the senior population is a vulnerable population as well, especially when it comes to social determinants of health. Medicare Advantage plans were given new options in 2019 with supplemental benefits to address what might be considered non-medical needs. I'm wondering how your plan is using those, or what you're learning from how to best apply those supplemental benefits.
Well, I'd say we're still learning in process. We added a meal benefit post discharge to help people stay nutritious. We have an in-home safety assessment, if you'd like. We'll come to your house, and an OT or someone will come and assess risks for falls or things that are dangerous. We have a transportation benefit in our special needs plan. It's often hard for people, harder now even than to get if you're low income, especially, get on a bus and get to a doctor, or get to an appointment, get your medicine filled. The we didn't do because we have the MLTSS program that wraps around the dual eligibles. We don't have as much need as we do in because we have Medicaid that wraps around the Medicare, and that has it's a whole raft of other social supports, personal services. And I think as we continue to move forward to this, as we look at ESRD joining the ranks of things that are covered next year, and people have a chance to join, you seems to me you'd be sort of foolish not to join an MA plan if you had ESRD because of the cost sharing required issues, and the benefits of care coordination too, of course, around place to place. So I think we'll see more of this as we move forward. Toward the end of last year, we formally organized something called, we call the Center for Social Impact. And its focus really is the business unit here, the health plan. They really try to address the issues. The big issues we're looking at are housing, nutrition, employment, intellectual disabilities, and loneliness. And trying to figure out where there are ways to assess this, ways to measure improvement, ways to cause improvement, and so forth. We also have a healthy food card for people with diabetics. And we have some very nice diabetic benefits in insulin coverage, the cost of meds for people with diabetes as well. Luckily for me, my colleague here on the Medicare program sent me a note to remind me about the diabetic food card. So a little hint from outside.
It's like call a friend, whatever that show was again. You get to get a lifeline.
That's right.
Nick, your model seems to almost automatically address a lot of these social determinants, but I'm just wondering your interaction with the plans, these supplemental benefits, and maybe describe where you'd like them to go. Where would you like to see more effort placed with regards to social determinants?
Well, fantastic for us, right? Because we get to play that somewhat of a care coordination quarterback role. We've dabbled with food pharmacy as well, and most of what we do though is truly coordinating with some of the community groups out there, right? Whether it's the food services, DME, whatever we can do. So applaud and welcome the fact that the MA plans have these supplemental benefits available. We work with them on how to best implement them. To John's point earlier, we're in the home, we're looking for those fall risks. We know whether do we need a ramp outside? What does Joe or Josephine need for the household, and what can we take advantage of that's included in those benefits? We leverage all of it to the extent that we can for the patient. So, I think along the lines of food is a big one for us. We don't see it everywhere. We have nutritionists, as I mentioned, on our team, and dietitians as well that come up with programs. So better access to that. We have a bit of Medicaid. We're primarily Medicare Advantage right now. So different dilemma on the CAID side, obviously, but with Medicare Advantage and the supplemental plans, supplemental benefit plans, again, embrace them, try to take advantage of them where available.
It's such a huge difference to be able to go and see somebody, as Landmark does routinely, and as we do with care management, when you're in somebody's house and things that seem either they don't think they're worth mentioning, or you wouldn't think to ask. But I noticed there's no light bulbs in the lights, or there's nothing in the refrigerator, or there are 4 cords across the floor. You have 7 extension cords here plugged in as 1 cord. Things that people wouldn't even tell you about because why would you care? Right? The opportunity to sort of see how people interact with their families. I remember a visit once in which we found this woman with spina bifida who was a wheelchair user who lived with her dad in a pretty low income place, and the bathroom was on the 2nd floor, and she had no way to get up the stairs, and had, as you might imagine, constant UTIs because she didn't have the mobility or the help to get up and Dad never really told anybody that. It was just her life as she knew it, and it's just the way it was. So, and when you see those things, then when you're coincidentally or not, you really can then have an opportunity to do something about it.
Well, you remind me, I've been talking to medical groups and health systems about their rapid expansion of telehealth. And I remember talking to one endocrinologist who was surprised. He asked the patient to turn the camera around, look in the refrigerator, and he was just very illuminated. This is a patient he'd been taking care of for years, just what was in the refrigerator, what the patient was actually eating, which he had never known prior. So you're right, being in the home, either virtually or as you are physically can make a big difference in understanding how that patient is interacting with their environment and their condition.
One of the great insights of home visiting, I think, was, other than that certainly a good one as well, is looking in people's medicine cabinet.
Yeah.
You have 7 diuretics here, I think. We should probably talk to somebody about this.
And you know, Jerry, it's worth mentioning, and you know, very profound for us is you've got to build up that relationship over time as well, right? And one of the concerns we have, and this is not meant to be a competitive conversation, sort of with some of the other models we see, is you're sending someone different into the home all the time and coming in with that perspective of almost, as something John alluded to, it's almost like punitive, like I'm trying to find something, versus be in the home, build a relationship with the caregivers, with the family. Over time, that level of trust, you get to discover a whole lot, right? And get to influence as well. We had a training session last year at our annual event on smoking cessation, right? It's not lost on us that we know it's an issue, but at the same time, you know, we have patients that are smoking, they're relying on it. Like, how do you get them thinking about it? How do you get them onto those programs? You really do have to build that trust over time as well, especially when you're in the home.
And one of the things about Medicare Advantage is that patients stick with Medicare Advantage for a long time. And I think Allison again presented some statistics today. And over that time, you can develop that trust with their network of providers and their care system. And then you also, as Nick mentioned, have the opportunity to get ROI because you can invest up front and then see the benefits maybe in year 2 or year 3.
You know, for sure. I think our retention is about 97%, I think. So people are happy with what they get and they bring their friends.
Exactly. Let me, before we go to audience questions, and I'm going to check and see if we've gotten any, I want to talk about one of the things our providers, as I mentioned, our members want to move to value-based care, and they're challenged for a whole bunch of different reasons. But I'm wondering from your perspective, you're working with providers, John and Nick, you talked about maybe contracting with providers who are taking risk. What do they need to do now to be ready for risk and to move into these value-based arrangements? Let's start with you, Nick. What are you looking for in those providers that you may go at risk for? What sort of capabilities and competencies do they need to have?
Well, you know, first and foremost, the openness, and no pun intended here, to take the risk of you know, getting into a risk platform. It's not an easy one. You know, on the surface, it seems easy, but if you've been living in a fee-for-service model and you know, you've got 2,500 patients on your panel and you're doing your routine, and all of a sudden we start talking about doing population health, you know, value-based, and here are the risks, and we're going to establish this MLR. So open-minded, listen, you know, and start with, like, if you look at a model like ours, we're going in there, we're talking 5, 8, maybe 10% of the population in your MA book to start with. So start with that. You know, I don't like using the word pilot, but it's sort of piloting and start, build up that level of confidence and that partnering. Understand that, you know, groups like ours and others out there that have already built those tools, how do you leverage off of that? And over time, I think you take those learnings and you can open it up to the rest of, you know, your panel and the book of business. But, you know, just jumping in right away and switching over and build up those capabilities. I can tell you, it took a lot of years and a lot of learning for us to refine our platform so that we figured out how to do this right, because we didn't do it right out of the gates.
Got it. John, how about for you? What do providers need to do now to get ready for value? What are you looking for in your provider partners to make this work?
I think willingness to change is one thing, certainly. I think the ability to find or develop analytical skills at a population kind of level is certainly another. I remember going to a medical staff holiday party once in one of our hospitals some years ago when I was the bad news insurance guy, and very nice people. And the first thing people said about moving this direction was, well, I told my patients what to do and they don't do it. That's not I'm done. So, well, no, actually not. Yeah, yes, I'm sure you told them what to do, but did they hear you and can they do it? And what, you know, trying to think differently about the impact you have with your patients on your communication, and really be able to anticipate from the analytics where to kind of move. Here's my opportunities are. We're, I think, relatively speaking, pretty transparent with our data and explaining to people what we're looking at and moving to the ability, we'll just give you the data and you can sort it yourself and rather than do it on paper, but more than some are. And that helps to engage people because we want you to succeed. We don't want you to fail. it's not to our advantage that you fail at this. It's to our advantage that you succeed. So being open, I think, being willing to have dialogue, being willing to change, and being willing to think that more global population managed way.
Fantastic. The only thing I would add, John and Nick, is having a long-term perspective. I think you both touched on this. You're not going to do it overnight. It's going to be a journey, and you have to commit and realize you may make mistakes along the way, but if you're committed in the longer term with a partner, you can be successful. So we do have a question from the audience, and it is that BMA just released a report showing the rapid rise in MA enrollment for the dual eligible population. Maybe each of you talk more about how duals fits into your overall care delivery model in your business. Maybe start with you, John, since you mentioned that.
Sure, we have, as I mentioned, we have a standalone dual special needs plan. We have 3 of them actually, and they have about 34,000 people. They're different geographically. We've been in the duals business since 2006 when Part D came into place. It's a track. I think of course there's obviously no price point difference for duals because they don't really pay for anything. It's really the service, I think, when you experience it, and the benefits that will attract people. Especially the benefits that are tangible, like the SSBCI kind of benefits around transportation. I think it's hard for people to get in the abstract, say you're going to benefit from care coordination when you don't ever have any care coordination. What is that? That sounds annoying. It doesn't sound like it's helpful. But $3,000 of dental coverage, or hearing aids, or ride to the doctor, or food baskets are things that resonate with people. And then once you experience it, I think the care coordination, our retention rate is very high. And it's been bolstered really, our growth, by the implementation of MLTSS, because we have more ways to interact with people than we did before. So we have a very nice record of growth steadily over time, and it's really picked up in the last year and a half, the enrollment.
And John, to me, the advantages of Medicare Advantages seem to make so much sense for that high-risk population, vulnerable population who has a lot of needs. It just seems like an ideal match, and with the model and the flexibilities and the benefits.
Yeah, absolutely. And as Nick implied earlier, when you talk with people, you have the opportunity to learn they need help with housing, or it isn't like your doctor probably can't help you with their housing. They could give you a referral to United Way, or they would like to help, but they can't. So as you probably know, people are reluctant to ask about this because they don't have an answer. So if I ask you about a problem and I can't solve it for you, now I feel better, but worse. So whereas in our case, when we're talking to people about what makes it hard for you to take your medicine, or whatever the conversation is, when it's something like, I can't get to the drugstore, it's not safe to walk outside my house, I can't go walk a mile a day, then you have opportunity to provide different kinds of solutions. And I think people find that very few people leave, honestly. And our dual population is pretty young. The majority of people are not, I think, are under 60. Probably 60% are under 60. So it's a pretty, and those are therefore, of course, all people with disabilities. And that's a very different population of people than the older population is largely, this is not very much too broad, of course, 75 to 80-year-old women who are widowed, living alone in some kind of subsidized housing, who have the usual kind of chronic conditions of 75 to 80-year-old people. The under 60 folks are serious mental illnesses everywhere, substance use disorders, many physical complications, whether it's traumatic or congenital, and have a very different set of needs around care coordination.
Excellent. Nick, dual eligibles, how do they fit into your business model and your care models?
We like duals because it gives us, I alluded to this earlier, if you look at the Medicaid population, due to what I call a flawed reimbursement system and lack of risk, we have a tough time justifying the costs around that, to your question earlier, versus when I look at a dual population, now I've got the MA advantage, and I get to address and take care of a population that I would have struggled to justify bringing in. So we actually like duals, perform well with duals. The profile is different, as John alluded to. So clinically, pretty much the same, but logistically a little different on, how do we find them? How do we sort of stay on top? And how do we help them? But overall, like the fact that, duals populations are very conducive to what we do and how we can take care of them. Like I said, it allows us to expand on the patient population we can serve.
And just reminding the audience, if you have questions, enter them. While we're waiting for more questions, I'm going to throw you all a curveball. We are in an election year. And there is talk about expanding coverage for different populations, Medicare for all, public option. Just wondering your thoughts. What role do you think in expanding coverage, if we go that direction, should Medicare Advantage play? And I'll give you 2 seconds to think about it, and I'll start with you, John.
Well, I think if I'm going to adopt a slogan, I'd say it's Medicare Advantage for all, not Medicare for all. And the second piece would really around the integration, the better integration of the financing we need for duals. It's still two separate platforms that sort of interact, but there's a lot of room to improve. And we're doing a lot of work in that area around exploring direct contracting options, looking at different ways to align, because it makes it, for us, we have a lot of aligned people who we have both the Medicare and their Medicaid. And when we have aligned people, the quality is better, the revenue is better, the MER is better, the costs are less. It's just better all the way around of the whole group of people. It seems to be clearly the way to go.
I fully agree with John. Medicare Advantage for all. My conversation with Congresswoman Schwartz, I look at the direct contracting initiative as a great funnel opportunity to educate people on value-based and maybe attract them to models like this. Now I'm biased and respectfully to the government. I think private industry knows how to run sort of programs better, and yes, they need to be regulated and monitored. But there's an impetus for us, to do the right thing. I think we can manage populations better. So I'm Medicare Advantage for all. I'm a big fan of.
Fantastic. Good answers. I think that was good for this panel. I'm glad we answered that way. And it'll be interesting to see how that plays out. I think, from our perspective, if you want higher quality and lower costs, why not put them into a program, put expanded populations into a program that's been proven to work. Give you one last question. You get a magic wand. What's one change you'd like to see in the Medicare Advantage program going forward that you would recommend? So John, let's start with you. What do they need to change? Where are you going to wave your magic wand?
Do I get to design my magic wand too before I get to wave it? I think some more, some of the changes this year that CMS has made around the star rating system, I think the stars is what I think we should change. It needs to evolve into a probably more meaningful measure. Moving toward more customer satisfaction, I think, is a good move in terms of ratings. But I think some of the HEDIS measures could be more clinically meaningful than probably they are. I don't know if an A1C of 7 versus 8 in the population makes a huge difference. Whereas, can you get to see a doctor when you need one, for example?
Well, you're not going to get a lot of argument from our medical groups and health systems. They complain about the quality measures, too many, some of which aren't clinically meaningful and hard to engage the physician population on. So I think you'd get good agreement there, John. Maybe that's an area where they would put their eraser on some of those. Nick, you get your magic wand, and I think you may get the last word here.
Look, I'm going to get to cheat again, and I like John's answer, so I'll take that. The other one is, I still haven't gotten my head fully around it, sort of, the encounters versus claims and the whole coding, some better clarity around that would be appreciated. Overall, we find it works well. We're obviously biased. This is where we built the business around, and it's, the contract just works for us.
Well, that's fantastic. Well, again, I want to thank Better Medicare Alliance. I want to thank our two wonderful panelists who this hour went very fast as far as I could see. Thank you, John. Thank you, Nick. Thank you for the great work that you're doing for your Medicare Advantage and your other populations. And just delighted to have spent a great hour with you both. Thank you very much.
Thank you for great hosting.